past the hour. We will allow the first few minutes to be me introducing myself, and if people miss that, that's okay. I think most of the folks joining know who the ACLC is and know who I am. So if you join late, I'd rather you we'd get to our panelists sooner than later. But welcome everyone that has joined. I'm Tom Merrill, the Director of Research at the Accountable Care Learning Collaborative. Really good to have you with us today, especially in the midst of a pandemic. The ACLC continues to move forward, and committees are wrapping up, and we have some other things on the horizon. So those of you who are members, you will be very plugged into all the things that are on the horizon, and those of you who are guests, will give you a bit of an intro into the kind of work that the ACLC does. If you're here today, hopefully you are here for the right webinar. This is the report webinar from the Committee on Medication Optimization. We'll talk about what that committee did and their timeline here in a minute, but hopefully you're in the right place. For those guests who are visiting us today, a brief review of who the ACLC is. That stands for the Accountable Care Learning Collaborative. It was formed as a collaborative organization to bring stakeholders together from all facets of healthcare to identify the competencies being demanded by value-based payment models. You can see here that we have a pretty diverse group that have come together under the ACLC, and the shorthand is that we seek to have these conversations in order to help providers know what they should do, number one, when they should do it, number two, and how they can implement it. So a very collaborative process from A to Z. And all of this, all of the work that we do ties back to one of our foundational and guiding documents, the Accountable Care Atlas, as you see here. This is a document that was built a couple years ago and is actually in the midst of being refreshed, but was our attempt to get all of the competencies that were being demanded of providers into one place. And as you can see, it's a lot. And we tried to lay it out systematically. This is a resource that we have on our website. You are all welcome to access this. And there are resources that go along with it that make it more actionable. This is more demonstrative, but it just shows you that this is the work that we have all been involved in, and surely there's work that lies ahead. So real briefly on the way that the committees work, we have multiple committees per quarter that center around just one of those competencies. So if I can go back, you can see one of these blue, yellow, red, or green guys. We have one committee dedicated to one of those, and they basically just build out guidance on that. They start, it's a 3-month committee. It's a bit of a sprint. In this case, this was the Committee on Medication Optimization. They started with pre-session interviews. We had one meeting in January, another in February, and another in March. And usually they're in person, but because of the COVID pandemic, we met virtually for all 3 of these meetings. And this is the sort of last step in that process where we share the output from that committee with the broader ACLC and the public at large. So all are invited to these committees, these committee report webinars. Just real quickly down below, as a bit of a shout out, you can get a sense for the Q3 and Q4 committee cohorts. That's 2019. The Q1 and Q2 of 2020, you can see that this falls into Q1 committees that are wrapping up. We also had one on data aggregation. Q2 committees, which included home-based care and high-value partnerships, those will have committee report webinars next month. And I had the privilege of overseeing home-based care and know that the output of those 2 committees in particular were really strong. And we hope to share them as widely as possible, and hope that you'll join us on those webinars. Okay, let's jump into this particular committee without any delay. I was mistaken on that timeline. They met from February to April, so not January. And I think that had to do with a shift in the, we shifted the timeline. So anyway, let's jump to who comprised this committee. So as you can see on the left, we have a number of folks that are veteran members of the ACLC. So Don Bechtold of Jefferson, Amy Matthew of New York Presbyterian, Norm Ward of One Care. These are folks that have been contributing to the ACLC for years. But for this particular committee, it was a bit bleeding edge. Well, most of these committee topics are, but this one just required a huge presence of expert guests that I'll let you read on your own. But the one to note is Amanda Brummel, who is with us today from Fairview, who will be representing her committee. So we will focus on Amanda and her organization, but we will also invite her to give us a bit of a sense of how that committee went. And then importantly, we also had sponsors on these committees. And for those who are guests today, this is how that works. The sponsors allow for essentially non-paying members to join these committees and benefit and contribute. And we're very grateful that they are willing to sponsor these committees. The first is MHA. We'll hear from them a little bit later. The second is Pharmaceutical Council, or MPC, and that's represented by Kimberly Westrich. We'll hear from, I neglected to mention the name of Tim, who will be representing MHA, but we'll get a sense for who they are later and why they chose to sponsor this committee. But we are very grateful that they did. It allowed for some just really important and productive conversations. Let me review real briefly something we call the competency framework. And I'm going to be brief because this particular competency framework will be included in more detail, with more content, I should say, in the publications that will come out in the weeks to come that will be attached to this particular committee. I'll talk about that in a moment, but real briefly, the competency framework is essentially an outline for the committee. It's how we organize the discussion, recognizing that something like medication optimization can be very, very broad, and those discussions can meander if you don't kind of narrow it and give it some organization. So this was our particular committee's stab at organizing the topic of medication optimization. I think it turned out really well. You can see at the highest level, we call those sub-competencies. So for example, sub-competency number 1 is to use data to identify opportunities for medication optimization and to measure success. And then within those, you see sort of some sub-elements, if you will, that sort of break that out into more detail. The whole point of this is to give an overview. We know that you could spend weeks, months, probably even years talking about this topic and how it can best be carried out within your organization as you pursue value-based care and operate under value-based contracts. The point of this is to give executives an overview as they think through the various things that's being demanded of them. Just going back to the atlas, there's a lot. A preview of the committee outputs. I mentioned that the competency framework would find its way into one of the documents. That's the one on the left. It's a competency orientation guide. It's exactly what it sounds like. It's supposed to give you an orientation of the competency because it's only 2 pages. There's no way you can really understand everything the committee went through, and obviously the individual committee members and what they know. But this, it's almost like a city guide. It gives you a sense for where you may want to go if you're looking at this destination. On the right-hand side, we have the case study brief, and this is also a 2-page document. That's why we call it a case study brief. It's meant to give basically a really powerful anecdote as a complement to the COG. If the COG is somewhat abstract, the CSB is very specific, and our case study subject is Fairview, which is why it made a lot of sense to have Amanda Brummel from Fairview be our webinar subject, because Fairview is doing great things, and we took just a snapshot of what they're doing, and that will be available in the next week or in the weeks to come. And so the screenshot you see is from Montefiore, so pay no attention. It's Fairview, and we're excited for that to come out. All right, well, without any further ado, I'm going to bring in Amanda Brummel, who is our subject today. She is our committee representative, and I wasn't involved in these committee meetings, but from the committee staff, we know that that Amanda made a huge contribution to this, as Fairview has continued to make a huge contribution to value-based care generally. And of course, they did it with, they're doing it with medication optimization as well. So let me, before I get into questions I have for Amanda, I'll let her briefly introduce herself and her organization. Amanda?
Hi, thank you, Tom. Good afternoon, everyone. Again, Amanda Brummel. I'm the Vice President of our clinical pharmacy services at Fairview and have been there for over 20 years. So have been very passionate about medication optimization, and much of what I'll share with you, has been part of my journey there. So thank you for listening. Fairview in general is a large integrated health system. We have over 10 hospitals with 50 plus primary care clinics and over 60 specialty clinics. From a pharmacy standpoint, we also have a large infrastructure. We are our own LLC as a part of Fairview Health Services, and we have over 900 employees that are just within our ambulatory pharmacy departments. So I like to say that we kind of have every flavor of pharmacy under the roof outside of nuclear medicine. And so when we talk about medication optimization, it really goes broadly in to us, of course, delivering product and making sure that patients have what they need, but then all of the infrastructure around that, making sure that those medications are optimized, from our comprehensive medication management program to our community pharmacies where we're doing, adherence work and immunizations, and our specialty pharmacy that are focusing in and doing clinical services with those patients as well. So very broad reaching, again, medication optimization is something that we're very passionate about.
Awesome. Thank you, Amanda. So the first question we have for you is, the documents that will come out will speak to, what does medication optimization look in general? That's the point of the ACLC, is to have 10 or so organizations as part of a committee and abstract from those 10 what is common across the 10. What are the common lessons or principles, if you will? So the first question is, what does it look like specifically at your organization? You just touched on a few things, but you just give us a bit more color.
Yeah, so I think, like many, when we think about medication optimization, we really go back to any of the same population health pyramids or anything that you think of, from which patients need interventions across the board, your base and foundation, that our level of service that all need and are going to have, up to the top of our pyramid, which for us in medication optimization is our comprehensive medication management program. We have 45 pharmacists in over 54 locations that are seeing patients directly one-on-one and making sure that each of their medications is indicated, that it's effective, safe, convenient for them. So really, again, focusing in on those highest risk patients, but throughout our level of the pyramid, making sure that there are interventions all along the way to make sure that medications are optimized. And that could be within our EHR and working with our partners and NIT and with our provider partners to look at clinical decision support and how we manage our medications when, at the front lines when people are ordering those medications, to, again, after those medications have been ordered and making sure that people are able to stay on them and get the most out of their medications.
Okay, great. It sounds like a lot, and it sounds very, sounds comprehensive. Next question would be, I know that the committee covered a lot, and there will be a lot of insights that find their way into the competency orientation guide, but given your experience, Amanda, and how much you've seen over the years, what was there one or two takeaways that came out of committee discussions that's just really stayed with you?
Yeah, I would like to commend all of my colleagues that were on the committee. I think there's a lot of great work that's happening throughout the country and a lot of learnings that we shared. And I think, a lot of similarities that we also found in themes of opportunities that we've taken across our systems. I think some of the takeaways for me is that it's really important to have a long-term vision of what it means for medication optimization. And sometimes when we're working within our contracting world, sometimes there's a lot of short-term visions and strategies, and those are important, but it's also important to have that long-term vision and to think what you really need to get out of medication optimization. I think we also talked a lot about how to really build that up within our systems and how to partner across our systems to make sure that we have the right tools in place, and how sometimes those tools can be very complex, but being able to optimize and use clinical decision support tools and protocols and pathways to help guide our clinicians in making the best choices with their medications. So there's a lot of takeaways that I could go over, but those are probably the top two that really resonated with me.
Okay, great. Thank you. So the last question would be asking you to look into the future just a little bit, at least for your organization, and that is what's the next phase? Fairview's done quite a bit here. What are you looking at going forward?
Yeah, so we're all in a new world, right? And it's amazing in many ways. The things that we wanted to do for a decade, we've made happen in months. You know, but I think, you know, long term and again, big picture with medication optimization, I think it's continuing to innovate. We are doing what we're calling primary care transformation, looking at some of our sites and looking at how we best utilize all of our team members and how we best ensure that we're kind of moving the practice forward and taking those next steps. So we're going to continue to innovate in that world, and again, make sure that the pharmacists that's integrated into those teams are really seeing the patients that need them the most. And, you know, again, in my 2 decades of doing this, this is always something that you're continually learning and enhancing and improving upon. I think, you know, to my earlier comment with all the changes we've had, we're definitely in a different virtual world as well. And so I think we will continue to look again from the tools that we're using to how we're interacting with the teams. And in a lot of that, we can remove some of those physical barriers that are there and really optimize some of the new virtual technology that we're using. So I think that's another opportunity. And then finally, again, with kind of that clinical decision support, we're really working a lot on what we're terming care maps, going from inpatient to outpatient, where a lot of our kind of care mapping before primarily lived in the outpatient world. We're really trying to connect again across that system and make this much more fluid for a patient. So gives us plenty to work on and to optimize, and exciting new things to look forward to.
Yeah, you definitely do have plenty to work on. Here's a bit of a bonus question, Amanda, and I'm realizing we didn't give you any advance notice of this one, but it's just coming. We're constantly trying to evaluate what we're learning from this pandemic. And so my question is there anything about the preparation that you've been doing specifically on pharmacy, medication optimization that has been challenged by the pandemic, or actually maybe even prepared you for a new, care approach, a temporary care approach under the pandemic?
Yeah, I mean, I think such a large question, and I could probably spend a lot of time on that. I think from a delivery standpoint, really things didn't skip too much of a beat. And we've done a few different things just even around site of care within our system that I think will serve us well in the future. So what I mean by that is taking patients that needed to come into an infusion center and deciding, could we do things in the home, and how do we make sure, and we're already doing home care, but we did that expanded within some other therapies. And again, really surrounding the patient and making sure that they had what they needed in home, and making sure that was a safe environment. I think with our comprehensive medication management pharmacists, right now, they're all working remotely from home. So that's something that we've never done before, and we're able to learn where we had strength when the pharmacists really had their own panels of patients versus maybe newer clinics where they were still building, and the difference within those practices and how we can really be fluid and work across the team, how much our care teams have depended and need our support within our patient population. So I do think we have some good learnings. I think other things that we'll continue to look at and be able to reflect on in hindsight of how did this differ, and what opportunities do we have to improve.
Yeah. Okay, well, thank you so much, Amanda, for sharing your perspective, your experience, and like Dan said earlier, we're really appreciative that you were able to contribute to this committee. So, and thanks for joining us today.
Thank you.
All right. Okay, so the last portion of our webinar today is we wanted to feature our sponsors for a moment, because it's not every day you get to have sponsors that are so squarely operating within this space and have so much to offer, including like we're about to see with the National Pharmaceutical Council, so many additional resources that are just that are available to the public. So the first sponsor that we're going to have introduce themselves is Kimberly from the National Pharmaceutical Council. And my first question, or the first thing we've asked Kimberly to do, is just to tell us a bit about her organization and why they chose to sponsor this committee in particular. So Kimberly?
Thanks, Tom. I'm Kimberly Westrich with the National Pharmaceutical Council, and I'm really happy to be here today. And it was just such an honor and a privilege to be able to be one of the sponsors for this activity, which we think is really important. And as you mentioned, Tom, really well aligned with some research we've been doing for a while. For those of us who are not familiar with the National Pharmaceutical Council, we're a health policy research organization that's based in Washington, D.C., and in a nutshell, we focus on the role and value of innovative medicines to help achieve better health. And we do that through research, which I'll tell you about in a moment, and partnerships like this partnership with the ACLC, and hosting educational events like this webinar. So it fits very squarely in our wheelhouse. And when you think specifically about ACOs and the role and value of medicines in achieving better patient health in ACOs, medicines often have the opportunities to help ACOs meet their quality and cost benchmarks. So this is an area that we've been doing research on really since 2012, and it gives us an opportunity by sponsoring this to share some of that research and to help further an area that we've been focused on for a while. And if you go to the next slide, Tom, I can tell you a little bit about those resources that we have available. So this is historical resource, just looking backwards. In 2012, we did get involved in putting together a framework for the role of medicines in accountable care organizations. And a shout out to Amanda. She was involved in a lot of the research that we did from the beginning. She's been a great contributor all along, and really one of the leading edge ACOs to look at in this space. And we've learned a lot from her. And so the framework just lays out what it looks like. We did 2 surveys, one in 2014, one in 2017, looking at the readiness of ACOs to optimize medication. And I think that fed in really nicely to the work that this committee has done. We have a case study series, and our first case study was with Amanda and Fairview, and it highlights some of the areas of best practices and ways that other ACOs can work to optimize medication use. We also have a series of work that looks at quality measurement in accountable care, kind of what's the landscape out there, where there's some gaps in quality measures, and what are some of the solutions to start filling those gaps. And finally, we did some quantitative research to look at the impact of ACOs on utilization. So those are resources that are available to folks who want to do a little bit of a deeper dive into this topic, and hopefully they'll help complement the competency guide and the case study that will be coming out of this work. And then on the next slide are just a couple of things that we have underway to keep an eye out for. Obviously, for a lot of this year, we've been focused on the work with the ACLC group. We have 2 activities coming up, though, which I think are interesting. One is in the space of value-based contracting, and we've done a lot of work in value-based contracting looking at it broadly, but this particular project is going to be focused on IDNs and what does value-based contracting look like with an IDN. So what is the landscape? What might a framework look like? So that's something that we're looking to turn around pretty quickly this summer. You can keep an eye out for. And then we'll have an article in December in the Journal of Managed Care and Specialty Pharmacies Vintage Rerun series. And I see Amanda smiling because I think she has an article coming out in this series earlier, maybe September. And what they're doing in this series is picking articles historically that have represented a seminal activity. Our article will be the medication optimization survey that we first did in 2014. Amanda, I think yours might be on medication therapy management. And it's a nice opportunity to look back and see, what did you write? Amanda's is like 10 years of medication therapy management, and now 10 years later, and a new 10 years. And then ours will be looking at how have things changed in medication optimization. And it's going to be a great opportunity to leverage the work that this committee has done and the information that came out of the core competency guide and the case study on Fairview. So that's what we've got underway, just for folks who would like a deeper delve into the topics.
Awesome. Thank you, Kimberly, for that background. And it's pretty obvious why NPC would want to sponsor a committee like this. And clearly, this is only the tip of the iceberg. The COG, by the way, the committee competency orientation guide on page 2 points to multiple of these resources. So it's a nice little connection point as well. Okay, Kimberly, so I'll put you in the hot seat for a minute. And that is where, despite hours and hours of collaborating with really smart colleagues, you have to pick 1 or 2 takeaways that you had from the committee deliberations.
Sure, it is always hard to pick out a top takeaway, but I think one that I want to highlight is really thinking about ways to maximize the role of the pharmacist in the system. I think when it comes to optimizing medication use, one thing that we talked a great deal about is the role of the pharmacist, and pharmacists being able to practice at the top of their license, and how really embedding and engaging them into a patient's pharmaceutical care, their overall care, is going to help you maximize the value that you are getting. And it's something that we're seeing is particularly timely. Just yesterday, the National Forum's Value and Access Steering Committee put out a statement, policy statement, really pushing for change and for policy changes that will help pharmacists be able to practice at the top of their license and maximize the value that they can bring to the system. So that's really one of the areas that just stood out for me as being something that is long overdue. There are some places, some states that have made progress in it, but it's time, especially in the pandemic. We really see it's time.
Yeah, that's an important one. A smarter workforce, it sounds like, definitely was a clear takeaway. Okay, so last question I have for you, Kimberly, before we switch over to Tim, is what is one thing that you think that our audience today, either watching live or recorded in the future, should keep in mind as they watch this subject going forward?
Great. So one thing that I was thinking about is what the takeaways are perhaps for the pharmaceutical industry. Our members are the innovative biopharmaceutical companies. And when I think about what's an important takeaway for us as far as how we can partner, how we can help, I think it's really critical that we are able to quantify the value of our medicines, that we're able to show ways that our medicines can help optimize quality for the patient, ways that they can help lower costs or make total spending more efficient. And that the takeaway for me is just how important it is for us to have that data and that evidence to be able to show value and help us be good partners. So that's my takeaway there.
Awesome. Well, thank you, Kimberly. Again, really grateful that your organization was willing to sponsor this committee. You contributed so much, and you as an individual, I know, just had such a profound effect on the nature of the conversations, and it's all better that you were with us. So thanks for being with us.
Thank you.
Okay, now let's switch over to Tim, who I will give Tim maybe a brief introduction as someone who is very generously pinch hitting for our permanent committee sponsor representative, who was Michelle Templin, who many of you know is a veteran contributor and sponsor of the ACLC. MHA, Managed Healthcare Associates, is also, as an organization, a veteran sponsor and has just contributed a lot over the years. And so Tim isn't going to get the hard questions that we gave Kimberly, because Tim didn't have the benefit of being part of the committee, but we're grateful that he was here willing to join us and at least give us a moment to reflect on what MHA does in the marketplace and understand a little bit more through that why they chose to be a sponsor. So Tim, are you there? Can I switch this over to you?
Yep, we're good, Tom. Are you hearing me
Go
okay?
ahead. Hearing you loud and clear. Hi, Tim.
Okay, perfect. Well, for one, I appreciate you having me. So I've been with MHA about 2 years now. I serve as the executive assistant and legislative liaison for MHA. Do apologize that Michelle wasn't able to attend. She's a part of several committees dedicated to both educating our members on accountable care initiatives and legislative advocacy opportunities for our members. But just to get some insight as far as our company at MHA, we are the largest alternate site GPO in the country and a leading healthcare and software company. We just celebrated our 30th year anniversary in 2019, and we also serve almost 15,000 members across the following areas in home infusion, especially pharmacy, retail and clinics, senior living, and long-term care pharmacies. If you go to the next slide, please. As a GPO, we do have extensive contracting in pharmaceutical, medical products and services, business products and services, and food service. Our LTC Medicare Part D network, we're able to negotiate long-term contracts that secure reimbursement rates for LTC pharmacies. Then we also offer several software services such as NetRx, CTM, MHA Link, SoftWriters, and SHP. And just in regards to our ACO network, we do have compiled over 1,300 members, where we're strategically positioned members to work in conjunction with both Medicare and commercial ACOs to meet the triple aim of improved patient care, improved population health, and lower healthcare expenditures. Our specialty pharmacy solutions, sorry about that. Our specialty pharmacy solutions, we're able to get specialty contracts and software and technology solutions, associations and partnerships, as well as clinical services. And through our clinical services, we're able to provide a dedicated clinical expertise in senior care, specialty in home infusion pharmacy. And lastly, we do have our legislative team, which I'm a part of, where we build strategic relationships with key stakeholders to effectively advocate for members in the alternate site marketplace. So appreciate you guys having me. And like I said, I know Michelle apologizes as well for not being able to be here, but thank you guys for having us.
All right. Well, thank you, Tim. And that is the most, MHA does a lot and a lot of good stuff. But that is the most succinct version I've ever, that phrase, alternate site GPO. All of a sudden, a lot of things are making sense, and clearly why MHA would want to, bring their experience to this particular topic, because we know pharmacy is not just retail, it's not just hospital. People are getting medications in the home, and I think that sort of dovetails nicely with what we're experiencing right now. Care moving to the home and the different competencies that are required for that kind of approach. So now we move into the Q&A portion. I think we only have about 8 minutes max for this. And so I think at this point we look to the queue. Bree, I'm not seeing the queue. Let me see if I can bring up the queue. But basically, if you're out there, let us know what questions you have for the committee. And I will ask Bree, I think I'm seeing it, but I want to make sure. Bree, do we have any questions in the queue? It doesn't seem like it to me at this point.
None that, no, not right now.
Okay, so be thinking. And I will ask the question that I was wanting to ask, and that is, this is for anyone who feels like they have something to share on this. And the question is, I mentioned at the top of the webinar that one of the things that the ACLC is structured to do is to bring provider organizations. That's most of who we focus on with the committees, with obviously the multi-stakeholder approach, but the focus is on how do we help providers develop the competencies to do these kinds of things, or think through it. And oftentimes we have committee members, organizations like Fairview, represented by Amanda, who are pretty far advanced. And so what we try and do is try and find principles that, for no matter where you are in that journey, whether you're a Fairview or you're just starting out, that these resources make sense and can apply. So to Tim, Kimberly, and Amanda, I'll just pose that question. If anyone is willing to jump in this, and that is, for an organization who is just starting out, is there a principle that seems to just apply really, really well in the beginning when you're just starting out? Any thoughts? And if neither of you three answer that, Bree has to answer the question.
Oh dear.
So this is Amanda. I can take a stab at that. So I mean, I think in general, in looking at your organization as a new ACO or getting into this work, I think one of the first things that you can do, again, is, well, there's lots of first things that you can do to start out with, to be honest. But I think, again, being able to focus maybe in some key quality areas, and or if there's some key total cost of care areas that you see. So depending on what branch of that triple aim that you want to maybe focus in on first, if you're looking at that from a quality area, there's lots of documented evidence on how medication optimization or having a pharmacist as a part of the care team has improved quality outcomes. So being able to identify if you have an area of need and looking across that could be a first step. I think if you're looking at total cost of care, again, there could be lots of opportunities there. And I think to Kimberly's point earlier, which was spot on, a lot of times we have medications continuing, right, to be a bigger part of our total cost of care spend, and trying to understand, are there medications that we want to use that better optimize the care within a patient, or if we're just going to have expensive medications, because medications are expensive, we want to make sure they're effectively working in that population. Because there's still some of our best lines of defense that we're going to have in treating patients, right? So it's not necessarily always getting rid of the medications, but really making, again, sure that those are optimized and that they're being utilized appropriately, and that patients are able to be compliant with those medications. So if you kind of just looked between those two areas, that would be my initial suggestion for kind of where do you go and how would you start? And Tim and Kimberly, you feel free to just jump right in and share your thoughts as well.
Sure. So I would just, to add to Amanda's points and just kind of stepping back and looking at it broader, I would say don't reinvent the wheel. You know, there are people like Amanda, like Molly Ekstrand, the folks on our committee who have been deeply embedded in this for a while now, and they know what works, they know what doesn't work. And it is really helpful, I think, to have those learnings in a core competency guide, in some of the case studies that we put together, the case study that's going to come out. You know, people who have been experiencing this and learn some of those lessons. I think one of the best things that a newer ACO or people who are moving into this world can do is learn from folks who have been there and don't reinvent the wheel.
That's a great insight. And I think one of the things that's clear that we need to do is probably clone Molly and Amanda, given the amount of industry involvement they have and publications that are coming out from those two. So let's work on that medical technology. Okay, other thoughts or questions? Bree, I'll check one more in the queue to make sure we're not missing anybody, but
Nope, no other questions.
I think we're good. All right. So if there's not any additional thoughts or from the group, I think we have a ACOC principle that we are not afraid to finish a webinar a few minutes early. So I think that will be it for us. In terms of next steps, we have these publications, which will be on the website in the next week or two. You will find them under the committees tab. So you go to committees and then you drop down, it says resources. Actually, I think I'm wrong on that, Bree. I think you go to committees, it takes you to a page, you'll see all the committees. You click on the committee for medication optimization, you'll be able to see the resources there. And including the recording of this webinar, which we encourage you to tweet out, especially those who were involved. This was a really great insight and a fantastic discussion. Help us spread the word and share these resources as they are free. So, all right, once again, Kimberly, Tim, and Amanda, thank you for your time today, and Bree for keeping us organized and hosting this, and we'll see you guys all on the next committee report webinar. Have a good afternoon.
Guys.
Thank you.
Thank you.
Bye, guys.